Welcome to GP Trainee Teaching Lockdown Learning Session 4. Today we're going to cover sexual health, musculoskeletal, and talk about GP partnerships. Okay, so I think we're good to start. Let's begin. So those that have been before, welcome back. Those coming for the first time, thank you for joining us. Let me just do a brief introduction for any of you that are coming for the first time. My name is Dr. Mohibur Rahman. I'm a portfolio GP based here in Birmingham and in Solihull, and I'm the medical director of eMedica. So I do a mixture of clinical work in my own practice, in various other settings. We'll talk about that in a bit more detail next week when we're going to do portfolio careers. And then the bulk of my time now as the medical director of eMedica, I'm involved in teaching and training doctors at various stages of training for MRC, GP, AKT, CSA, GP careers. We do some things for medical students, and then I do some consulting for people like the MPS on e-learning and medical education. So that's my background. And I just, before we get into this, I just want to share this picture. This is actually from a webinar I ran on Tuesday night for our AKT Pass Guarantee program. And just highlighting that, look, we've been in lockdown now for more than 6 weeks now, and it's dragged on, and it can sometimes seem like there's no end, but I just want you to remember that this too will pass, okay? And I think especially if we look at the data the last couple of weeks, it does look like we're probably beyond the top part of the peak, okay? I'm not saying we're out of the woods yet, but this will pass and we're getting there. And similarly, a lot of you have been waiting to hear in limbo about the cancelled exams from AKT and CSA. And there's some light at the end of the tunnel for that too. I'm going to talk to you about that, but just, stay positive and, thank you for joining something like this to keep your learning going. Okay, we're going to do teaching on 3 topics. It's going to be interactive, so please do get involved with the questions and the cases. There'll be rapid reviews of current guidelines and discussion. 3 topics I mentioned. Just before we get into those, just a brief update on the MRC GP exam. So the cancelled April AKT, the RCGP have said that they're going to try to hold that in July. The exact details as to will it be open only to those who had booked April, or will it be open to new applicants? Will preference be given if they can't fit everyone in to those who are due to CCT in August, or will anyone that had booked in April be available to book? Those haven't been finalized yet, and exactly the date of it hasn't been finalized, but they've said that they want to hold it in July so that those that are due to CCT in August won't be delayed. And then the cancelled March, April, May CSA, the options are still being considered, either to have the current format of the exam and either hold that in RCGP headquarters in London, or to try to hold it regionally, or to have a slightly different assessment format where they might get you to do video recordings of consultations and maybe some audio of telephone consultations and have those assessed by examiners. Actually, in the old MRCGP, they used to have video consultations that we used to record and send through. Okay. The key message, though, is the exams are going to come back online. The final details haven't been sorted out, but they're going to come back, and that nobody's going to be exempted either exam. And so just continue your revision. I'm glad that those of you that have joined the first 3, that you've kept it going. And, it's important just to keep that going. Okay. Right. So in terms of the program of today, now we've got that out of the way, this is what we're going to do. We're going to cover sexual health, a musculoskeletal case, and then the careers topic today is GP partnerships, and there'll be a Q&A at the end. We're going to be finishing promptly at 8:15. Okay, so in terms of sexual health, we're going to look at 3 things, and that's because in both the AKT and CSA, what you'll see things that are really common. Chlamydia, gonorrhea, relatively common STDs, and so it's important that you know how to deal with it. But you'll also see things that are a lot less common, so rare but more serious, like HIV. You're probably going to see patients with chlamydia or gonorrhea, in clinic. If you're in GP, you'll probably see a case of that every couple of weeks. HIV, you might only see a patient with that a few times a year. But especially when you're making a new diagnosis or testing for it, you need to know what you're doing because you don't want to miss it, right? Because it's a lot more serious, the consequences, okay? So let's go straight into a question, okay? Right, I'll close the poll there. Right, I'm going to show you the second question before we go through the answer, and that's because this is an example of what we call an extended matching question. So in the AKT, extended matching questions come in sets of 2, 3, 4, or 5. So you can see sexual health 1 of 2. 2 of 2 will have exactly the same answer options, but a different question. Okay, so we're going to do 2 of 2 first, because you'll see if I explain the answer to the first one, it might give away the answer to the second one. So let's do the second question. Here we go. Right, so the second one, a lot more spread. So people picked A, B, D, E, F for the second one. The first one, the two most popular answers were B and D. Okay, so I'll just go back now and show you. So the first one, so you can see here that this patient is positive for chlamydia, and that quite often fits. About 70% of women with chlamydia have no symptoms at all. Okay, and so the fact that she's asymptomatic, you know, it's important we screen anyone that might be at risk or is worried about it, because of the fact that it is so commonly asymptomatic, especially in ladies. So as I said, the popular answers were B and D, azithromycin and ceftriaxone. The correct answer is D, azithromycin 1 gram orally. Okay. Now, something important about this is that this question is saying which of the following is the most suitable initial treatment. So that key word, it doesn't mean it's the only treatment or the complete treatment. It's initial means first step. Okay. So for example, this patient, they'll be given azithromycin 1 gram PO. That's on the first day, right? But then you're going to give them a prescription for 500 milligram tablets to take the next day and the day after. Okay. So chlamydia, most common STD, about 50% of all new cases in the UK are of chlamydia. It's asymptomatic in the majority of women and also in about 50% of men. But when people do have symptoms, the kinds of things they might have, sort of UTI-like symptoms like dysuria, dyspareunia, so painful intercourse, abdominal pain in the lower abdomen, PV bleeding sometimes in between periods, testicular swelling and tenderness for men, purulent or watery or milky penile discharge, and then for women, an abnormal pervaginal discharge. And first-line management, there's 3 options recommended in the NICE guidelines. So doxycycline, 100 milligrams twice daily for a whole week. That's contraindicated in someone who's pregnant. Azithromycin, so that was the answer for this question, 1 gram on day 1, then 500 milligrams on day 2 and day 3, and then they're finished. And then ofloxacin, 200 milligrams twice daily for 7 days. So if we go back to the options, you see ofloxacin and then doxycycline, they weren't there. And so that's why azithromycin 1 gram is the most suitable initial treatment. Okay, so that was the first one. Now the second one, there was a big spread. It just highlighted it was a difficult question, right? A, B, D, E, F were all picked. Okay, we know this is an area that people often struggle with, because a lot of patients, they will go to GU clinic, right? They'll go to gum clinic to get tested and treated for these. But what the NICE guidelines say is that some patients don't want to go. We can and we should treat and test these things in primary care. And that's why it's in the guideline and has come up in the exam before. So in this case, it's gonorrhea. And this man had some of the typical symptoms, a purulent penile discharge and urinary frequency. A lot of the symptoms overlap between chlamydia and gonorrhea, which is why I almost always will test for both. Even if I'm strongly thinking of one, I would rarely just test for the one. I'll test for both. Okay, so the right answer for this one was B. Okay, and actually only about 20% of you got this one right. So very challenging question. And it's ceftriaxone 1 gram. A lot of people picked 500 milligrams. That used to be the dose in the old guidelines. And often when guidelines change, they will test it in the exams that come after it. The reason that they changed it to 1 gram is that a lot of patients weren't recovering on 500 milligrams. And it was thought that because the dose was insufficient, you were getting a partially treated case and then they were getting recurrence and it would be often worse the second time around. So the latest guidelines recommend 1 gram. The nice thing about this is just 1 gram IM one-off dose. So I'll administer it in practice. Okay, our practice specializes in sexual health, so we do a lot of tests and treating for this. So gonorrhea is a lot less common than chlamydia, thankfully. Only about 7% of new cases, and it's asymptomatic in about half of women, but in men it's almost always symptomatic. Only about 10% have no symptoms. Okay, and there's a lot of overlap in terms of symptoms to chlamydia. So the ones we mentioned for chlamydia, you can get a lot of those as well. A couple of differences. So the PV discharge for women may be quite thin and watery or sort of green. It can in men cause inflammation of the foreskin, so redness and swelling of the foreskin, and then the discharge for this isn't milky. It tends to be yellow or green, so it's sort of purulent. Okay, first line treatment for this is 1 gram of IM. As I mentioned, that's in the updated guidelines, is 1 gram rather than 500 milligrams was in the old guideline. Okay, so let's move on to a statistics question. Remember, statistics is one of the domains in AKT, but it's related to chlamydia. So have a look at this. You can use a calculator. Okay. And that's time. Thank you very much. I'll leave the poll open in case some of you haven't already done it. But the correct answer is C, 0.566%. A few of you sort of getting there now. A lot of people picked A. A lot of people picked H. Okay, and quite a few people picked some of the other options as well. So they've all been picked. But I'll just close that poll off now. Okay. So what's really interesting is that H was a very common answer. Now, this is very, very common. Why? Because H, 4.1%, is the prevalence. And this question's asking about the incidence, right? Often people will get the answer wrong because they're just doing the wrong calculation. Okay, so incidence is the number of new cases out of all of the population. Okay, so it's new cases. New cases is 124. We can totally ignore the ones that were already coded with this diagnosis in the past. Do you see? That's part of prevalence, but it's no part of calculating incidence. So 124 out of the total population of the practice, 21,898. Okay, and then you've got to multiply by 100 to turn it into a percentage, which is where you get 0.566%. So those of you that picked A, which was also another really popular answer, the reason that you did that is you forgot the last step. You didn't multiply by 100 to turn it into a percentage. That's why you would have got 0.056%. And those that got H, 4.1%, you would have done that because you got 124 and you added it to 784 and then divided. That's how you calculate the prevalence, okay, is the total number of cases, i.e. new cases plus existing cases out of the population. That's prevalence. Incidence is just the new cases, 124, okay? So incidence is the rate of new cases of a disease. We either report it as a percentage, that's quite common, 5%, 2%, 0.5%, or as a proportion of the population, i.e. number of new cases per 100,000, or number of new cases per million, or number of new cases per 1,000, okay? And usually you do it over a period of time, like 1% every year, i.e. number of new cases every year. So to calculate, all you do is the number of new cases divided by the population. To turn into a percentage, what is percent? It's per 100. So you multiply by 100. And if you want to do it per 100,000, then you would multiply by 100,000 instead of by 100. If you want to do it by per 1,000, multiply by 1,000 in that last step. Okay, but the first step is just number of new cases divided by the total population. Okay, and then you multiply. All right. Okay, let's look at HIV testing. That's time. Right, so the popular answers were A and D. So 6 weeks and 12 weeks were the two popular answers, although all the options were picked by at least one person, okay? So the key thing here, there's two. One is having the knowledge. The second is technique. So the knowledge is knowing there's something called the window period. In the window period, even if you've got an infection of HIV, one, you might not have symptoms. Two, the test might show back negative. And so if you have a negative test within the window period, you have to retest outside the window period. So the window period is 12 weeks. Okay, so that's the knowledge part of it. All right, so the correct answer is D, 12 weeks. The technique part, some doctors, they see, okay, you had the test 4 weeks, and they think, okay, so then after another 8 weeks, 4 plus 8 is 12, okay, then, you know, we should have a reliable test. But the question wasn't asking how long from now should he wait before he repeats the test. If the question asked, when should you ask him to come back to repeat the test? The answer would be 8 weeks, right? Because he had the test 4 weeks ago, and now you need to wait another 8 weeks. The question asked, though, how long after possible exposure can a negative test reliably confirm that he does not have HIV, i.e., how long is the window period? That's another way to look at this question. So the right answer is 12 plus weeks. So once you're outside the 12-week period from possible exposure, if you have a negative test, then it means it's negative, okay? So a couple of things to be aware of. First of all, who to test. Anyone that requests it. You don't have to sort of have a good reason, i.e., if someone might have increased risk of HIV, it comes out from your history, you might suggest a test. Someone comes in and says, I'd like to be tested for HIV, and they don't really want to talk about why. Don't worry about it, just test them. Because sometimes people might be embarrassed. Maybe they've had an affair. Maybe, for example, they paid a sex worker, or maybe they're just embarrassed about what had happened, and they don't really want to talk about it, okay? But they might be scared because they might have a risk, right? So we should test them, because if they are, we need to know about it so that we can treat them. All right, think about contact tracing, think about reducing transmission, and so on. Okay, so anyone that requests it, we test them. And then in our history, if we find someone at increased risk of HIV, we want to test them. I'll give you a list of who's increased risk in a minute. Pregnant women, as part of routine antenatal care, it's one of the set of tests that are done, because if someone is picked up to have it early on in their pregnancy, there's additional things that we need to consider, okay, in terms of reducing risk. And then people with symptoms suggestive of HIV/AIDS. So think about some of the kinds of symptoms that someone might have. Just put that into the chat. What kinds of symptoms might someone present with that might make you think, you know what, maybe I should think about counseling them and then testing them for HIV? Anybody? Okay, while you're doing that, I'll carry on. In terms of counseling, if a test is negative and it's before 12 weeks after the exposure, we must repeat it 12 weeks or more after the exposure. Why? That's the window period. During this period, antibodies might not show up, so the test might show up negative, okay? If you get a positive test, we always confirm with the second test. Why? Because having a diagnosis of HIV will impact things like getting life insurance, travel insurance, but also, of course, we need to test you. You know, you're going to be on treatment and have contact tracing, and the treatment is for quite a long time. If you definitely don't have it, we don't want to give someone the treatment. There's a lot of side effects of things like Truvada and Caletra, okay, the sort of some of the things that we might use, okay? So a negative test doesn't need to be disclosed to insurance companies, but positive tests do. Okay, so people have put some things. You might get flu-like illnesses. You might get things that are specific to AIDS or HIV, like Kaposi sarcoma. You might get a maculopapular rash in the early phases, general tiredness, pyrexia of unknown origin. You might get frequent infections, just a clue that you've got a weakened immune system, right? Okay, pneumocystis jirovecchia, we get silent breathlessness. Okay, quite typical of that. That's quite specific. It's one of the AIDS-defining illnesses. Okay, sudden changes in weight, GI symptoms like diarrhea, night sweats, getting some lymph nodes swelling, out of the blue. So these are lots of things. Often it's non-specific, isn't it? Okay. And these are some of the patients who have increased risk of HIV. So if you happen to be in an area with a high local HIV prevalence, more than 2 in 1,000, all new patients that register should be tested. Someone who's a sexual contact of someone known to be positive, from an area, get a patient who is newly joined the practice and their origin is an area of high HIV prevalence. Men who have sex with men or female sexual contact of MSM. Someone with multiple sexual partners, a history of an STI or injection, drug user, victim of rape, occupational exposure. So, you kind of a healthcare worker with a needle stick injury, okay, or a blood splash or something like that, okay. Now, just before we carry on today, a few people have asked about how to prepare for AKT. Because we now have a date for the exam, just to let you know that we ran our statistics webinar, which is 3 hours covering all the key stats topics, our organizational domain webinar, which is 3 hours covering all the key admin topics, our high yield clinical grammar webinar, which is all of the high yield clinical topics examiners mentioned in their examiners reports. We ran all of these in April. Okay, and then we also had our AKT course, our main AKT course, which covers all 3 domains, covers exam techniques, has 3 teaching mocks, and then access to a full 200 question mock. All of these, we have online recorded versions, which are up to date because they've been updated just in the last, well, they were updated in April. Okay, so all of these recordings are bang up to date with the latest guidelines, and they're all available to subscribe anywhere from a month to 12 months. And then I mentioned these last, I think in the first one, are high yield clinical case cards. These are the 2020 edition, published March, 112 topic reviews covering things like investigation, diagnosis, prescribing, management, emergency. These are the areas that questions are drawn from. So these are all things that you might find useful. For all of these, we've got a 20% discount. That's all of our recorded webinars, our online courses, our online revision. We've got 1,700 plus AKT questions. We've got 65 plus CSA cases, our case cards. The code is lockdown. That code will expire on the 7th of May. It was actually due to expire at the end of this month, but we've extended it because they've announced exams, okay, to allow a few other people to sort of benefit from that. So I just want to mention that. But I want to move on now. I want to do a musculoskeletal interactive case. Okay, so I show you the patient details. This is how it's presented to you in the exam, right, on the iPad. So have a quick look at that. And then I'm going to be the patient, and I'm going to ask you to use the chat to ask me questions. I'll answer them live, okay, as if I was the patient. And then we'll see if we can work out what might be going on and if we can manage it. Okay. By the way, some people have asked questions in the Q&A. I'm going to answer all the questions at the end, okay? And I'll answer them in the order they were asked, all right? So don't worry, I will get through all of the questions before I head off, right? Great. Okay, so let's make a start, okay? So I'm the patient, okay? So I've knocked and I've come in, all right? Someone's asked, how can I help today? Doc, I've been having some pains and I just need some help with it. Okay, so that's the opening line, just some pains. Very broad. How are we going to narrow it down? Who'd like to ask something else? Let's have a look. So there's a slight delay in the transmission, so I'm just waiting for the next question to ask. Okay, so someone's asked, still an open question. Good to have a couple of open questions. Tell me a bit more. Well, Doc, I mean, I've been having pains probably for quite a long time now, but the last few weeks, as well as the pain, I'm getting other things, and the pain's getting worse. And so it's mostly my hands. That's, you know, the main thing that's causing problems. Okay. So someone's asked, can you tell me a bit more about the pain? Well, I mean, what do you want to know? Okay, so someone's asked, what time is the pain? Well, I can get it different times. It's worse in the morning. First thing, it's really bad. I don't know if I'm sleeping on it awkwardly or something like that, but you know, it's really bad. And it gets a bit better throughout the day, but I still do have some pains throughout the day. Does that make sense? It doesn't completely go, but it's worse first thing in the morning. Someone said, how did it start? And I just noticed it one morning. Yeah, a while back, just noticed it one morning, and then gradually it's not gone. I've tried a few things, but it's not settled. So I thought it's too late now. I need to come and sort it out. It's starting to get in the way. Someone's asked, any stiffness? Yeah, definitely. Both hands just feel really stiff in the morning, and the pain's worse then. Someone's asked, any other joints involved? No, it's mostly my hands. I mean, I sometimes get the odd twinge in my knee, in my right knee, but the main thing is my hands. Okay. Someone's asked, what type of pain? It's like an achy pain. Someone's asked, have I tried anything? Yeah, I've just tried to take some paracetamol. It helps a little bit, but I think because it's getting worse now, I found at the beginning the paracetamol was enough, but now, like, I'm having to take it nearly every day I'm taking like 8 paracetamols. I'm getting fed up of taking it, really. They only let you buy so much. Like, you buy a packet of 16, that only lasts 2 days, and then I have to go back again. Someone's asked, any skin rashes? No, my skin's fine. I mean, I have some dry skin, but I've always had some dry skin. I just use some cream for that. But that's not new. Someone's asked, any swelling? Yeah, actually, my joints are quite swollen in my hand. Yeah, especially like the knuckle area. It's quite swollen. Someone's asked, have I got a fever? That's a great question. No, I don't feel hot. Nothing like that, doc. Any changes in sensation? No, it feels normal. It's just, it's just like that pain and that swelling and stiffness. Someone's asked, any discoloration? It is a bit red, where it's swollen. Sometimes in the morning it's a little bit red. Yeah. Someone's asked, what job do I do? So I'm carpenter. That's one of the things why I've come in. It's actually, that stiffness is getting in the way now at work. I'm finding that it's quite awkward now to use my power tools, my drill especially. I haven't got that same sort of like gripping is quite hard. I can't close it properly. Someone's like, any family history of arthritis? Yeah, actually, my dad had a knee replacement. He had like arthritis of his knee, and he had to have a knee replacement. He was 65 when he had that. Yeah. Someone's asked, any change to my vision? No, my vision's fine. Someone's asked, any discharge from down below? Doc, I'm not here about down below. What are you asking about that for? I've come about my hands. I got pain in my hands. What are you asking me about that for? How long? That's a good question. I think the first time I noticed it, probably about, let me think now. Yeah, it was about 4 months ago, because I remember we just finished a big job. We did a big extension, and that was like the first time I noticed it. But I'd say it's been really bad the last 3 weeks, and like getting worse now. So can you point in which area? So like really, all of my both hands, like these joints, worst here, I'd say. Okay, like on the knuckle area. Someone's asked, any change to my weight? Not really, doc. I mean, I'm trying to lose weight, but I've been struggling with losing weight. I've not lost any though. Someone asks, how long does the stiffness last? I'd say probably I get up about 7. It's still stiff by the time I get on site, which I'm always on site by 8:30, and then it gradually eases off that stiffness. I'd say probably about 2 hours or so, somewhere around that. Okay. Someone's asked if I drink alcohol. No, I don't drink at all, doc. Does the pain ease at the end? Yeah, I mean, it gets a bit easier. I think once I get going, the stiffness eases off and the pain's not as bad. But also, you see, I've had some painkillers then, haven't I? So, like I'll have some with breakfast. Okay. Someone's asked, what do I think it could be? Well, I mean, as I say, my dad had arthritis of his knee, and he had his knee replaced. I don't know if I could have something similar. Someone's asked, how's my mood? Doc, my mood's fine. I'm not here about that. I'm just here about this pain. If you could help me out with this and tell me what's going on. I'm right-handed. Someone's asked, what am I, left or right-handed? Thing is, it affecting both hands, though, doc, but I'm right-handed. Yeah. Are my joints more misshapen than usual? Well, they're swollen. I don't know about misshapen, but they're definitely swollen. Someone's asked if I smoke. I smoke the odd cigarette. Just like, if I'm on the site and someone offers me one, I don't smoke it regularly. It's more like a social thing. I don't see why that's relevant, though, doc. I'm here about my joints. Okay, so I think we'll pause the data gathering there in terms of history. Let's see what are some of the things that might be important. So in terms of pain history, you want to have some kind of a structure, right? Okay, so a couple of people have mentioned Socrates, or you could use PQRST. So if we go into PQRST, for example, what provokes it? How did it start? What makes it worse? Okay, and then Q, the quality, the description. So it's achy. R, radiation. Does it go anywhere else, or does it travel up the elbow, for example, up the arm? S, severity. If you had to put a number to it, how bad is it? That would be important to know, right? T, sort of timing. Is it worse certain times of day or night? We found out it's worse in the morning. It's more stiff for an hour or more. And then we want to look a bit more details of the joint. So, is it just one joint or is it many joints? In this case, it's many joints. It's all of the small joints of the hands. Is it symmetrical, both hands? Any swelling? Yes, there is. Warmth, does it feel hot? That's a really important question to ask. I didn't see that one. Someone might have asked it. I might have missed it because there's a lot of questions in the stream. Stiffness and getting the detail of it. That was a really good question. Someone asked, how long does the stiffness last? A couple of other things. If I'm working as a carpenter, could I have banged it? Could something have fallen on it? Any trauma, for example? Any recent history of travel? Lifestyle. Alcohol's relevant. Why you might be thinking about things like gout, right? Okay. Smoking slightly less relevant in this context. Other symptoms, asking about skin, really good. So, if someone had a new rash or scaling, you might think about psoriatic arthritis, right? Often, patients will get joint involvement. 1 in 4 patients, they get joint symptoms before the skin changes. Okay, so it's still worth thinking about. Eye symptoms, urinary symptoms, you might ask about if you're thinking about reactive arthritis, right? Things like that. Okay, and then family history, okay, of not just rheumatoid arthritis specifically, but any other sort of autoimmune conditions, so like things like SLE, other differentials. You've got to think about your differential, right? Okay, good. So let's move on to the next phase. We've probably got enough history now. What do we want to examine? What are the things that you'd ask this patient to examine? Just type that into the chat. What would we like to examine? Okay, so the joints, yes, great. What else? Any specific tests that you like to do on the joints? Anyone know any names of specific tests that you might like to do on the joints? And what else? Okay, so the small joints of the hands, okay, good. We want to look at the skin, yeah. Someone said the squeeze test, all right. Look for a rash, great. Check the lymph nodes, you might look for that, yeah. And then, yeah, the classic with any joint, right? Look, feel, move, right? So have a look at it. Does it look swollen? Does it look red? Feel it, okay? You're feeling for bogginess. You're feeling, looking for range of movement, okay? After that, all of those things, right? You might look at the eyes. You might check the temperature, okay? To see if they've got a fever. Okay, good. So I think we've got most of what we'd want to do. So you want to check the temperature, look at the joints, check if they can make a fist easily, okay? Can they do that easily? Can they flex their can they flex their fingers? Can they do that? Do they have any deformities like these? Okay, things like that. And then this is what we find: afebrile, swelling and tenderness of the small joints of both hands. So the PIP and MCP joints are involved, and they're unable to make a fist fully. They can sort of partially make it, but they struggle to completely close the fist. Okay, and then someone had mentioned the specific test. Okay, I'm going to show you how to do the Metacarpal Phalangeal joint squeeze test. So the MCP joint is this one, right? Okay, and the squeeze test is you get them to have their hands like this, and then you try to squeeze the joint. Let me see if it shows that way. So you try to squeeze it together. Let me show it this way. Squeeze it together. Now, if squeezing it together brings on pain, if I just squeeze that together, like if you do it on yourself, that shouldn't cause pain. Might be a bit uncomfortable, but for someone with rheumatoid, typically, if you do that, it brings on the pain, right? And it's not just to help you with the diagnosis. It's actually, if it's positive, it's associated with a worse prognosis. Okay, so I've given away the diagnosis there. I was going to ask you, what do you think the diagnosis is? But I think most of you have worked out that this fits with suspected rheumatoid, right? We're not saying it is yet, but it's possible. So what tests are we going to do in terms of like blood tests, imaging? Do we need to do anything? Anyone think what we'd like to order for this patient? Just type that down. Someone's already put down FBC, U rate. For this particular patient, there's probably no point checking U rate, but FBC, that's definitely something we would want to think about. What else might we check? Rheumatoid factor, anti-CCP, someone said, okay. We'd want to get x-rays of both hands, okay. Anchor, maybe ANA, ESR, okay. So a lot of people have got most of those. And in terms of management of drugs, so we want to give an NSAID at the lowest effective dose. So they've tried paracetamol, but that's not going to help with swelling, and they had swelling, right, okay. So, things like ibuprofen, naproxen, diclofenac, or one of the coxibs, so celecoxib, etoracoxib, all of these are useful. You're always going to prescribe a PPI when you give an NSAID, because these patients are going to be on this usually for weeks, okay? And then in terms of bloods, so FBC, ESR, U's and E's, LFTs are often mildly raised in patients with rheumatoid. The U's and E's you're doing as a baseline. Why? Because things like NSAIDs, if they're going to be on it for some long time, they can affect your renal function, can't they? So it's good to have a baseline. FBC, ESR useful as inflammatory markers and to check if they might have an infection. Then rheumatoid factor and ANA, and then anti-CCP, so anti-cyclic citrullonated peptide, anti-CCP. It's a really good test. Rheumatoid factors, about 70% will be positive, ANA about 30%. The reason this is a useful test is you can use it to monitor prognosis as well, okay? And then imaging, X-ray. Okay, so we've done all of that. Let's look at how quickly we're going to refer this patient. I'll launch the poll for this again. Again, you can see it's a hard question because every option's been picked, okay? The most popular options are D and C. So refer within 2 weeks was the #1 option, okay? And then after that, it was C, refer to be seen within 3 weeks. Neither of those are right, okay? The right answer is actually E, refer to be seen within 3 working days, okay? And this is an area, again, where the guideline recently changed. This guideline changed last year, and this is why we're covering it, because often where guidelines change, they'll be tested, both in AKT and CSA, okay? So well done. About just under 15% of you did pick E, but that highlights the vast majority struggled with this particular question. So in terms of suspected rheumatoid, the general referral is within 3 weeks. However, this patient warrants an ultra urgent referral. So refer within 3 working days if small joints of the hands or feet are affected, if more than one joint is affected, and if the symptoms have been present for over 3 months. So this patient actually, any one of these is enough to do a 3 working day referral. But he had all 3 of them. So small joints of the hands are affected, more than one joint, because he had both PIP and MCP joints on both hands affected. And he said that it started about 4 months ago. So he's got 3 good reasons why he needs a 3 working day referral. Everyone else, if they don't have any of these 3 very high risk factors, then it's within 3 weeks, okay? What you shouldn't do is you shouldn't delay the referral while you wait for the X-ray or the blood results to come back. Why? Because if they've already got swelling, if they've already got synovitis, they may already have the startings of joint damage. And that's why what we're giving with the NSAIDs is to help symptoms. It will not affect disease progression at all. Why do we need to get them seen quickly? Because what we're trying to do once they've been seen by rheumatology is they're going to start the disease-modifying anti-rheumatic drugs, so things like methotrexate. They're going to actually arrest and reverse some of that damage, right? And so that's why it's important to get them seen quickly. Everyone within 3 weeks, but any of these 3 very high risk factors within 3 working days in the current guidelines, okay? Right, and in terms of interpersonal, how might you explain, just type that into the chat, how you might explain, I'll enable it again, a diagnosis of rheumatoid arthritis, and for example, how this might be different to the arthritis that his father had, who had a knee replacement, okay? And then you want to talk a little bit about the natural history of this illness. Right? That would be something really important, right? So let me just see a couple of what people have put. Okay, someone's asked, will rheumatologists see him in 3 working days? Yes, that's what the guideline is, okay? Okay, so someone said about that you might ask what he already knows. Yeah, that's a good starting point, but how might you actually explain it? Okay, so someone said that this is an autoimmune condition where the body attacks the joints and causes destruction and deformity. See, the last part of that's really, really nice. I really like that, okay? That, sometimes the body can parts of the body, if you like, can attack other parts of your own body and cause damage to the joint, and it can affect the shape. We've got to think about language when we talk to patients, because if you use something like autoimmune, they might not understand clearly. So you actually have sort of explained it yourself in that second part, and so that's much clearer. So look, you could talk about the fact that there's different types of arthritis. The type that your father had, if they needed to have any replacement, is the type that often comes because of wear and tear. Okay, so that wear and tear type of arthritis, it happens to us all as we age. And sometimes if someone, for example, they're a runner, they're putting more pressure on their knee joint or their ankle joints, they might have more wear and tear, and they might get it sooner. That's why you often see sports people, athletes, get that type of arthritis at an early age. There's another type of arthritis where you get a lot of swelling and you get changes to the joint, and that can happen because parts of the body are sort of attacking other parts of the body, if you like. Okay, the body sort of recognizes that this is a threat in some way, and there's a reaction which causes swelling, and that can lead to long-term damage and destruction of that joint, and that can cause pain. It can cause changes to the shape, and this is why it's important that we get you seen by the specialist quickly, because the painkillers we've given you will help the pain and it can reduce a bit of the swelling. But what they're not going to do is actually stop this disease progressing and getting worse. And that's what we want to do, because ultimately, without slowing down that progress or stopping that progress, it can lead to disability. It can lead to permanent damage to your joints. Okay, so that's an example of how you might, describe the difference between this and the other type of arthritis. Okay, right. Okay, so that's. I just wanted to touch on a musculoskeletal case, and actually that particular case is adapted from one of the 100 cases that we have in our CSA 100 case crammer videos. Okay, so basically these are just some of the cases that we cover. What we have is we have a subscription available anywhere from 1 month to 12 months. You can use that same code to get a 20% discount on that too. But we go through 100 cases. It's based on a full day course that we did where it was over 8 hours. For each of the 100 cases, we go through the data gathering, so key things to cover. What are the red flags? How to sort of focus down when you've got limited time. What are the relevant things to examine? I show you how to do the examination. We look at the current guidelines for the management, okay, how to manage it according to the latest guidelines in a concise way. We look at and practice the interpersonal, how to give a clear, concise, confident explanation. And then of the 100 cases, 20 are interactive cases where we have a simulator and, people are asking questions, and you'll see in the video, it'll give you a chance to think about what questions you want to ask. And then the questions are answered live. I ask the question on behalf of the audience, and then the simulator answers it live. And then you can sort of see, okay, what would I do next? Where do we go from there? Okay. So, we go around those things. Okay. So it includes 20 interactive cases. You also get over 500 slides, the PDF booklet's over 100 pages covering those 100 cases, so that you can, not only can you watch back the videos as many times as you want, but you also have the PDF. You can make your own notes as you're watching, so that you can actually come back. So someone's asked, is that a webinar or face-to-face? So we do hold webinars for it, but we haven't got any scheduled for the foreseeable future. Up until the exam restart, we're not going to do another live one. What we have is a video recording of the last one that we ran live, okay, so that it's it's up to date. Okay, so that's available. Right, so we're going to move on to the careers topic now. So we've got 15 minutes to talk about this and take questions and answers. So we'll talk about this for 10 minutes, and I'm going to do questions and answers for the last 5 minutes. Okay, so we talked about locum last week. We talked about salary the week before. We did an overview the week before. This week we're doing partnerships. Okay, next week is going to be portfolio careers. So let's start, as ever, getting you involved. Use the chat to just maybe talk about the advantages first. What are the benefits? So just if anyone isn't clear, what is a GP partner? A GP partner is part owner of a GP practice, of a GP business, okay? So you're not an employee, you are one of the owners of the practice, okay? So what are some of the advantages of being a GP partner? Something that some of you might want to do, after you've finished your training, maybe not immediately, but maybe a few years down the line. I opened my own practice and became a partner 3.5 years ago. So someone said you get more money, more control over the direction of the business. Someone else has said that you have ownership of the business. You're involved in decision making. Someone's put dollar signs. Okay. more independence of owning the business. You have more direct involvement, more stability. You got a greater say in which services and how they run. You get a share of the profits, more control. Okay. Someone said about more flexible. You're your own boss. You're the owner, decision maker. So a lot of common topics coming through. So let's have a look. Absolutely. Okay, you can keep them coming, don't worry. So in terms of advantages, average partner earns more than an average salaried GP by a huge margin. So average salaried GP, if you're working full time, might earn somewhere between 70 to 80, 90,000 pounds if you're full time. There are some that are earning less than that. Average partnership income from the last set of accounts that we have is 109,000 pounds income. Okay, and there are some partners that are earning more than 250,000 pounds. All right. It's possible to make money from the property. So, for example, if you buy a share of the property, once the property is paid off, if it's being used for NHS patients, the NHS will keep paying you rent every month for a building that you already own. Okay, and so you can actually make money from that side of things. Okay, you can shape the services. So you can have a say of, if, for example, you want to develop a specialist interest service in minor surgery, you could do that. If you want to offer joint injections, you could do that. If you want to offer extended hours, or you don't want to offer extended hours, you'll have a say as a partner. Whereas as a salaried GP, you might not have that say. Okay. You are self-employed, which means that there's additional things you can claim against tax if you're self-employed that you can't claim as an employee. For example, if you're an employee, you can't claim for courses. If you're a partner, you're self-employed, you can claim for any courses you go on. Okay. For some people, it's a status thing, that it's something that they always wanted to do when they first came into GP training. They always hoped one day to have their own practice. Okay, I have to say I really like having my own practice, more than anything for the fact that we could decide a lot of things ourselves. I'll give you an example, right? In our practice, we have 20-minute appointments. Now that works because I've only got one partner and we both got the same wavelength. We're on the same page. We both would much rather have less stress, have the time to do our job in a way that we feel we're doing it properly, and be under less pressure. That does mean we make less income, okay? But we're happy with that, do you see? But you can't as a salaried say, go into a practice and say, I want 20-minute appointments. If they're all doing 10-minute appointments, they're just going to tell you, off you go. We're not going to give you a job, do you see? Whereas if you've got your own practice, you can decide that if you like, all right? I just don't ever do appointments before 10 o'clock in the morning, because it means I can drop my kids off to school, stop off. This was before lockdown, but I could stop off and have breakfast somewhere. So I never have time getting my kids ready for school, and getting them out of the door and get them to school so they're not actually in the late book. That in itself is an achievement for me. Never mind me trying to have breakfast. But, I could drop them off, stop off, have breakfast, and then get to practice. And I don't start my clinic until, usually it's 10:30 actually, but the earliest I'll have appointments is 10. Again, I could do that in our practice. I couldn't do that if I go somewhere else. Okay. Stability, potentially it's a job for life. Okay. What about the downsides then? Look on the other side. Are there any negatives? If there are only positives, everyone would want to be a partner, right? What are the downsides of partnership? Are there any? Anyone think of any? Just while you're typing that, someone asked, is that average, is that before tax? Yeah, all figures that we've quoted in any of the webinars, it's all before tax. We will have to pay tax. They say the only two things that are unavoidable are death and taxes, right? Okay, the taxman will get their cut, and life is a terminal condition. Okay, so someone said you're liable for losses, responsibility, more commitment, being busier. If you have partners that you don't get on with, i.e. partnership disagreements, the responsibility, you have to deal with the admin side of running a business. Okay, that can be an additional workload. Okay, you could make a loss. Yeah, absolutely. Complaints, dealing with complaints, often as a partner you'll have more responsibility for you. The buck stops with you, the additional paperwork. Active involvement means that you can also take a hit. Yeah, absolutely. Great. So again, great. Lots of people have thought about these things. That's great. So yeah, if we start with hours, a full-time salaried GP is contracted for 37.5 hours, but will typically work about 40 hours. Full-time partner, your contract has no set number of maximum hours, but typical for a full-time partner to work 50 to 55 hours. Okay. Are you working a full day more than a full-time salaried GP? Okay, while you can make a lot of money from the property, and while you can make a lot more money, it's possible, the average income's higher. It's also possible to make no money and to go bankrupt or make a loss. For example, if your partnership is making no income, you still got to pay your staff. If you then have to shut the practice and no one wants to take over the practice, then you're going to have to pay redundancy pay for all your staff. All right. Now, imagine you've had a salaried GP in the practice for 10 years. Redundancy pay on the NHS is 1 month's pay for every year of service. So that's 10 months of a salaried GP who's on, say, £80,000. You've got to pay that out of your own pocket. There's no government money for that. Okay. So once you've paid all of that, you might actually make a loss. Okay, that's possible. So if you practice shuts down because you're not got enough, you've got a bad service, patients leave, the money leaves, you can't recruit, you're spending lots of money on locums, you go into a spiral. In the last 3 years, more practices shut down than in the last 10 years combined before that. Okay. When you become a partner, when you become a salary GP, you don't pay anything. In fact, you often get paid to join. Okay. If you go to an area that's struggling to recruit, they might give you a bonus to start. Okay. You see these things have come in again. When you become a partner, you'll have to buy into the partnership. Okay. And in some cases, you'll be asked to pay a lot more than the assets are worth and than the building's worth. That's called goodwill. That's actually illegal to sell goodwill in the NHS. It's legal for private practices, but it still happens. But also just having the money to buy in. If you're buying into a practice and you're buying into the building, you might need to find £200,000. You might need to borrow that money to buy in. Even if the practice don't own the building or you don't buy into the building, just to become a partner, you've got to buy into what's called the current account, i.e. the other doctors have paid in some money to pay for the furniture, the fixtures and fittings, and you need some money to cover paying bills and things, okay? So, you still might need to find £10,000, £20,000 just to become a partner, okay? Parity. It's possible that you could do the same hours as other partners and you won't get an equal share of profits until you get full parity. In some cases, it will take 2 or 3 years to get full parity. So there's a risk of exploitation there. Commitment. If you don't find that you're happy in a practice as a salaried, you give notice. Typically, it's a month to 3 months, and then you leave. In a partnership, you can't just leave like that. Typically, there might be a clause that if any one partner leaves, no other partner can resign within 12 months. So imagine someone's just left, and you're really miserable. That's why they've left. They've put their notice in the day before you plan to do it. You can't put it in for another 12 months now. Now imagine you're miserable somewhere, but you've got to stay there for 12 months. That could be quite challenging, right? Okay. You've got responsibility for all of your staff. Let's say your practice manager bullies your receptionist. Your receptionist could sue you, not the practice manager. They're going to sue you as the partner, okay, and take you to tribunal. And if you lose, you've got to pay them a year's salary. That's going to come from your pocket and the other partner's pocket. You can't claim that from anyone, okay? They're not going to go after the, why? Because you're the partner. Ultimately, responsibility falls with you. Let's say you're on holiday and the locum calls in sick because they're sick, okay? And you just can't find another locum. You're going to have to cancel your holiday and come in because ultimately you've got to provide that service. That's what your contract is as a partner, okay? You have no employment rights. So, you have no automatic sick pay, no automatic maternity pay. It's whatever's in the partnership agreement, okay? And then, if partnership works, it's a lot like marriage. In a happy marriage, everything's really, really nice. All right. I'm fortunate. I've been happily married coming up to 15 years. It's a wonderful thing. Okay? I found my soul partner and I'm really happy. But, if you're not happy with your partners, and I'm also really happy with my partner in my partnership. It was my best friend from medical school. We've known each other for 20 odd years. We've got on well for a long time. It's fantastic, right? But, I've seen partnerships where people don't get on and then it's like a divorce. It's messy. But imagine it's like a divorce and you have to still go and see that person every day and look at their face and you still have to work with them and go to meetings with them. Do you see? It's really, really stressful, but also it's hugely expensive paying for lawyers to deal with the breakdown of a partnership. Okay, so those are some of the downsides of partnership. Okay, so again, one of the things I wanted to highlight, there's pros and cons of any job. So to recap, income's much higher on average than salaried, and generally it's on a par or slightly higher than a lot of locums. Okay. Now within partnerships, there's different types of contract within the NHS. So you could be a partner in a GMS practice, in a PMS practice, in an APMS practice. Okay, and what you might make might be slightly different. So PMS practices tend to offer additional services. GMS is the most common practice type. If you're not sure about all of these practice types, we cover it in our admin webinar. It's one of the things that comes up a lot in the AKT. Okay, and then dispensing practices are practices in areas where there aren't lots of pharmacies, and they basically dispense their own medications. They tend to earn the highest. Okay, so you have liability for the business and the staff. So it's possible that if you don't do well, if you do well, you can make lots of money. If you don't do well, you can have no income. I know of a partner had 0 income for 6 months. By the time they paid for locums, paid all their staff, paid everything, they had no money left. So they had no income themselves. They were just living off their savings till their savings ran out. Then they shut the practice. Then they had to pay for all of the closing down costs because no one wanted to take it over, and they took a big hit. Okay, so it's possible to lose money. Okay, you're not an employee, so you have no automatic rights that an employee would have, like sick pay, maternity pay, things like that. The workload is a lot more than salaried. Typically, 10 to 15 hours a week extra compared to a salaried, okay, who's working normally the same number of sessions. And a lot of that is the admin side of things. So it's something that you have to really appreciate. If you've never been a partner, you don't realize the additional pressure that comes with running a business, okay? And then, but there's huge upsides. You have a lot more control. You can shape the practice over a long period of time. You can see the practice grow. You get to know, because you have that long-term relation, you get to know your patients. You have that responsibility. It can be very financially rewarding, but it can also be really professionally rewarding. I've really enjoyed, it was a lot of hard work setting up our own practice from scratch. I mean, we had to buy the furniture, we had to buy every computer, we had to get even things like, the vacutainers and blood bottles and plasters, everything from scratch, okay? But after we set it all up, and CQC registration was such a huge headache, once we'd done all of that, actually, it's been really rewarding having our own place, having our own practice. We've won contracts to do various other things. We'll talk a little bit more about that next week. I'm going to talk about portfolio careers. I'll talk to you a little bit about my portfolio career. All of those things, okay? And so it can be hugely rewarding, but I just want you to understand any job, there's good and bad. It's not all, good. No job is better than or worse in and of itself. It's what's right and suitable for you, okay? So, any questions, put them in the Q&A, not in the chat. I'm going to go through all the questions and answers in order. But just before we finish, for those that haven't got questions, just a reminder, 20% discount available on all of our MRCGP webinars, our online courses, the recorded courses, the online revision for AKT and CSA, the CSA 100, the CSA cases, the case cards. The code is lockdown, will expire on the 7th of May. So you've still got a week, okay? I don't want to rush anyone or put any pressure on anyone. I don't want you to feel, I've got to do it today. You've got time, have a look at it, see what you think. But if you're thinking of doing it anyway, if you do it by next week, you're going to get a huge discount, 20%, okay? And all of our online courses now have subscriptions from 1 month to 12 months, because we had a lot of people ask us, I'm in ST1, I'm planning to sit next year, but I just want to make a start early because I've got, young kids, busy job. I can't study all in one go. I don't want to do it crammed into 30 days. Can we? So we've now introduced 12-month subscription, 6-month subscription, and so on. And just before we go, do join the GP training support group if you're not already a member. I will send out the video recording and the slides tomorrow. Register for next week, okay, 7:15 to 8:15, and do share if you're finding it helpful with your VTS group, okay? And lastly, I want to remind you of this from Lao Tzu: the journey of 1,000 miles begins with a single step. Becoming a GP, that's a whole journey. Becoming a great GP is a journey. I'm nearly 20 years into my journey of being a doctor. I still learn something every single clinic I do. But it's the same for your exams. Some of you are right at the beginning of starting. Some of you might be thinking about July now, okay? If you were planning on April and then you pause your revision, just make a start, all right? The fact that you've joined this, you've already made a start, and I'm really glad. And then just do a little bit. Every day, do something. Revise one case card. Do one set of questions on it online. Practice one case. Watch one video, and slowly, before you know it, you've climbed this mountain. You're up there, and you'll see that fantastic view we looked at earlier. So, for those leaving, thank you very much for joining me. I hope it's been useful. See you next week. Okay, prepare, and you will succeed. Thank you so much.